Namaskar, I am Dr. K.K. Agarwal, President Heart Care Foundation of India and immediate past National President, Indian Medical Association. Welcome to our weekly webcast. Today, we are going to discuss on an important subject, and that is unusual fevers in the country. We have with us Dr. Neeraj Nischal, who has done his MBBS from Maulana Azad Medical College, then MD Internal Medicine from Maulana Azad Medical College. He did his senior residency in the same college. Then he joined in 2014 All India Institute of Medical Sciences in the Department of Internal Medicine as assistant professor. And his special interest is in the field of infections, control of infectious diseases, with a focus on HIV and TB. Why we are discussing this subject is because yesterday the government of Rajasthan has declared an alert, that is H1N1 alert. All over the world, specifically in the US, there is another alert of flu, that is H3N2. But in India, we have not got H3N2 because there are some cases of H3N2 in Bangalore, but they are still in the poultry stage. Human transmission of H3N2 is not seen. But H1N1, yes, over the last 3 days, more than 85 cases have occurred in Rajasthan and 10 deaths have occurred. So we will talk about H1N1. We also are seeing some surge of cases of a possible herpes simplex encephalitis in the city of Delhi. We will talk about that. We will also talk about the Gorakhpur incidents where the NCDC says that a large number of deaths can be due to scrub typhus. And we will talk a little bit about a scrub typhus, how to diagnose, because it's a new disease. I remember when we were in MBBS, we never saw a case of scrub typhus. Leptospirosis, which was a disease of monsoon, more known in the area of Maharashtra, specifically in Mumbai. Now cases are being observed in Uttar Pradesh, which is adjacent to Delhi. Therefore, all over the country, you need to talk about what is that leptospirosis. We will also talk about at the end about little bit what's latest in HIV, what is test and treat policy of HIV, and what about MDR TB. Is it increasing? And what about XDR TB? Are they increasing? Let's interact with Dr. Neeraj first on flu. Anything new about flu?
It's a good thing that flu per se is a mild form of disease. It's not that the panic which we usually have when we hear that this patient has got flu, especially the so-called swine flu. But it's not a disease which needs that we should be panicking about that particular disease. So most of this flu are self-contained disease which body will take care on its own. Only less than 1 or 2% people may have a severe form of this disease, especially those who are at the extreme of phases, either elderly or those who have some underlying immunocompromised status, whether it's a diabetic patient or it's a patient of chronic kidney disease who have already underlying problems. These patients are the high-risk group. These are the patients in which we have to be extra careful. Otherwise, most of the population basically need not be alarmed about this disease. The best thing to do about this is to quarantine any patient who develops symptoms of flu. That is very essential because prevention is the best cure for this particular condition. All this hangama which we have when this outbreak of this disease happened is because of the rapid spread of this disease. So it's very essential that at the very first suspicion of flu, that patient should be quarantined and should be quarantined for 3 to 5 days till he is asymptomatic. So most of the time they will not require extra treatment. Only the severest of the case will require admission and treatment with anti-flu medication, which like oseltamivir.
So some of our points which we have discussed in the past: no fever, no flu. That's one. And number 2 is no breathlessness, no admission. And that's what Dr. Nischal has talked about, is that if you have breathlessness, which will occur in less than 1% of cases, so 99% of cases will be a mild flu, they will not have breathlessness. So therefore, no breathlessness, no flu. Let's talk about the second part of this is the scrub typhus. Are we seeing more cases of scrub typhus? How to diagnose them? And in that particular, normally we talk about is that no antibiotic if it is viral, no antibiotic if it is, unless you have a diagnosis. But in case of scrub typhus, we do say that if you suspect scrub typhus, maybe you need to start doxycycline early.
So, scrub typhus, if you ask me, are we seeing more of the patient? I would say we are diagnosing more of the patients now. Earlier, what happens because of the widespread of common over-the-counter use of antibiotics like azithromycin, which takes care of scrub typhus. Maybe in the past we were missing this disease because azithromycin is as good as doxycycline in treatment of scrub typhus, and for any fever we are more prone of taking azithromycin. So maybe that was the one reason why we were not seeing too many scrub typhus patients. One, because we were not suspecting, and second, most of these persons used to take these medication which will take care of scrub typhus. But now that we are aware that this disease is not limited to the mountains and that type of area, we are seeing a lot more cases because we are suspecting this disease now. And if it is not diagnosed and proper medications are not given, this disease can be fatal. And we are seeing a lot of scrub typhus patients over the last 2-3 years in our hospitals. And with timely intervention, we are able to save most of these patients.
How will a GP diagnose scrub typhus without going into investigations?
So again, earlier the dictum that travel history was very important for these patients may not apply at this moment. Again, a patient who has fever, the typical scar which we describe in these patients, that may not be apparent because most of the time they are in the hidden part, and it is seen only in 20 to 30 patients, especially in dark skinned person. You may miss that thing because scar take time to develop. So initial bite mark may just be a small point which one can miss, but over 3-4 days that scar may develop. So daily physical examination in such patients become crucial because initially the scar may not be there, but with time it may develop. Again, it is seen only in 20 to 30%. So if you have a patient who are showing atypical manifestation in the form of, say, rapid onset ARDS, or say signs of meningitis where we are not able to identify any other organism. Even these patients have deranged liver function tests. So these patients who are not fitting into other common conditions, then possibility of scrub typhus should be kept.
So any patient with unexplained fever, you're not diagnosing him, rapidly going into ARDS, respiratory symptoms, or encephalitis-like picture which happened in Gorakhpur. Always look in the body, specifically in the legs, for the presence of a scar, which will have a typical presentation with and without localized regional lymphadenopathy. If you suspect, before you diagnose, give a shot of antibiotic. Maybe that becomes a life-saving. What about leptospirosis? Because I recall that people say leptospirosis means Mumbai, means the floods. But now we are seeing leptospirosis all across the country. How to diagnose, how to suspect?
Again, the leptospirosis patient, which we usually see either present with liver failure, signs of liver failure, or in the form of encephalitis. So these are two conditions in which we have to be very aggressive in treatment of the patient, which is supportive as well as antibiotic this thing. Diagnosis is basically serological diagnosis only, but clinical suspicion can save life. So if a patient is presenting with hemorrhagic manifestation with liver signs of liver failure with encephalitis, then leptospirosis, especially in the northern belt, where the agriculture is a prime source of income and the patient has a background of agriculture, rural background, then this has to be kept into mind. And the main reason is unsafe drinking water, which is being contaminated by the urine of all these important organisms like rats and all. They are the source of the spread of this disease. So if we have a person, especially from lower socioeconomic conditions, presenting with these manifestations and with a background of rural background or agricultural history, then one can suspect.
So there is a tip for the practitioners who are practicing and watching this program, that in jaundice, that is viral hepatitis, fever disappears, jaundice appears. So normally when you have fever and jaundice together, look for typhoid hepatopathy, look for dengue hepatopathy, look for malarial hepatopathy, and if these three are negative, rule out leptospirosis. So fever with jaundice, never diagnose it as a simple viral hepatitis. It may be something different, and if you delay your treatment, that can be fatal. Now, we have observed over the past many years that cases of fungal cases are increasing in the society, including skin infections, including pneumonia, including fungal otitis. And one of the reasons has been that people are misusing either topical steroids in every case of eczema, or they are giving topical or systemic antibiotics, or misusing heavy antibiotics for a milder case. Are we also seeing at your AIIMS cases of fungal pneumonia? Are they on the rise?
Yes, this is very important thing. Earlier, fungal pneumonia, we used to think that it happens only in those who are immunocompromised, say immunocompromised like HIV patients, diabetic patients. These were the two important patients, or chronic kidney disease patients who are on long-term hemodialysis. These were the patients in which we used to see fungal pneumonia. But now what we are observing that the fungal pneumonia in relatively immunocompetent patient is on rise. And like sir, as you said, the rampant use of antibiotic, broad spectrum antibiotic, that is basically giving a clear field for these fungus to grow. And plus the demolition of old structure and construction work, that can be again a source of fungal spores, and people may be exposed to these spores, and even slightest of alteration in their immune system will give them these fungus a chance to grow in their body. So maybe these are the reasons why we are seeing more of fungal pneumonia these days.
So if you get any person getting with fever and signs of pneumonia, and if he has been working near a construction worker, maybe there may be houses just adjacent to where the construction is going on. Always keep it in mind. Am I dealing with a fungal pneumonia or a fungal chest infection? Now, of late, from Gorakhpur, when we saw that in Gorakhpur, the herpes simplex encephalitis cases have gone down, because earlier we used to think that all cases of encephalitis in UP are herpes simplex, and scrub typhus came. But we still get herpes simplex encephalitis. Even yesterday somebody was calling what one of the residents from one of the hospital has developed a encephalitis. What about how to diagnose and how to do, should every case of encephalitis be treated with the antiviral drugs?
So again, that's a very tricky question, how to diagnose viral encephalitis. Again, the dictum for any encephalitis or meningitis is to do a brain imaging and do a CSF. So if in CSF we have ruled out the common bacterial infections, and MRI imaging, if usually that is the modality through which you can diagnose a case of herpes simplex encephalitis based on the specific radiological findings seen on MRI and specific brain area which is being affected. So usually, like most of the viral infection, body is going to take care of the viral infection. But yes, role of acyclovir in herpes simplex encephalitis is a well-known thing. So this is one of the most common condition in which antiviral can be used, herpes simplex, and even in varicella encephalitis one can use antiviral. That may be a life-saving thing. But most of viral encephalitis usually require supportive care, and that should take care of that patient.
So early antivirals, specifically if you're suspecting herpes simplex, unfortunately herpes simplex have some specific signs on MRI. Therefore, if you're suspecting encephalitis, MRI is far better than doing a CT scan. And if CT scan is normal, has no meaning, but MRI can pick it up and can give you a lead, and then you can give a antiviral drugs in these cases can be a life-saving. Otherwise, these cases will end up into sequelae. They may even survive, but the long-term sequelae in such cases leading to mental retardation, leading to brain insufficiency are very high. Now coming back to your main subject, HIV-TB. What's new? What's new in HIV? What's this treat and test policy? And what's new in XDR or MDR-TB?
So the government has must be appreciated for launching this test and treat policy, which says any patient who has been diagnosed as a case of HIV, irrespective of CD4 or WHO staging, he should be offered ART drugs. So ART drugs now are very more efficacious with lesser side effects. Compliance has increased because of once daily pill, which combined pill, which can be taken, and of course the discrimination stigma attached to this disease has come down significantly. Still there is stigma, but still it's much better than what it was 10-15 years back. So test and treat policy, it is expected that more progression to AIDS will be stopped because of this policy, and this disease will be more like any hypertension or diabetic patient, where you take medicine, disease will remain suppressed, and you will lead a normal life like any other patient. So it has become a chronic disease now rather than this thing. But again, what I will request that whenever you have doubt, whenever in a patient you have a high risk suspicion of HIV, so what we have a tendency to do it once, and then we label him as a negative patient. But if you have a high risk patient, or you suspect that patient may have HIV, always repeat it after some time, because the window period the current test may miss these patients.
And the government is now coming out with another few months as a self-HIV testing kits. That means it will be like a pregnancy test. You will be able to check up HIV at your own home.
Yeah, so and plus the government has also come up with HIV Act, which has now more or less given more protection to all these patients against stigma and discrimination or any.
MDR-TB.
So MDR-TB again, we will say that doctors are playing an important part in spreading this MDR, because if you not recently, but few years back, a study was published in one of the leading journals which showed that the variability in prescription of treating TB in simply in Mumbai, they found over 100 different type of prescription, which most of them were not based on sound judgment or treatment which should have been initiated for these patients. And this type of practice is actually leading to emergence of resistance. Second thing, the compliance of the patient. So it's also very important that doctor counsel these patients. What happens if a patient has pulmonary TB initially, is very sick? After taking treatment for first 2 months, definitely there is a drastic improvement in his symptoms, and he feels, okay, I'm fine, and chances of discontinuing medication is very high. So these are the practices which leads to emergence of drug-resistant TB. And now MDR, XDR has become a major cause of concern, because we are seeing a lot of MDR patients now. And if there are MDR patients, then definitely a certain proportion of those patients will be in the XDR category as well. So we will be left with no other option. We have to understand that tuberculosis is a disease of developing countries. So Western world is not going to help you in eradicating this disease. So it's us. There is no, of course, we have few of the promising drugs, but again, like said, we have nothing concrete in pipeline for future this thing. So we have to be very careful in whatever medicines which we have. They are wonderful drugs. They are very efficacious drug. The only drawback is the duration is longer. But if treated properly, this disease can be controlled and chances of resistance can be decreased. So compliance and duration and dosing, that is very important.
So remember a couple of things, that you have faith in your system, have faith in the public health systems, not only the private health systems, and in public health systems, understand that TB, MDR-TB, XDR-TB, HIV are absolutely free treatment and diagnosis is available from the government of India. So therefore, don't run around here and there. Don't be shy. Don't have a stigma. TB and HIV are no more a stigma. If you have them, go back to the best of the government sector. You have the best of the diagnosis and best of the treatments available. Maybe we are still waiting for Hep C. Hep C is now curable. The total treatment cost is less than 20,000. We are still waiting if the government of India adopts Hep C also as a universal 100% free treatment to the community. And that will be a big boon for the society. So if you suspect MDR-TB, XDR-TB or HIV, don't go here and there. Go to your nearest government public health system get notified, take full treatment to prevent, not only to get cured, and but also to follow a standard protocol which can protect you from other things. That's all for today. Let's thank Neeraj to be here with us, and thank you very much. And if you feel that this program was of use to you, of helpful to you, kindly share it with other people. Thank you, and we will come back next week with some other topic. Till that, goodbye. Thank you.